Good afternoon. My name is Rahul Bhakta with the USF Maine COVID Service. This is a quick presentation on the admission, management, and discharge of COVID-19 patients here at TGH. So let's start talking about, let's start with the pertinent histories and physical. So obviously try to pinpoint the day of onset of symptoms. This is important because if we can identify the day of onset of symptoms, lets us know what phase of the disease the patient is in, and then hence we can know what our treatment options are. Always try to identify any sick contacts and known exposures, including if patients are coming from ALF, SNFs, or have caregivers that may have given them the illness. These are the pertinent past medical histories you want to look into. The reason these are important because this may preclude or open certain therapies for patients. For example, with regards to biologics, if a patient is on Plaquenil for a rheumatologic disease, they're not a candidate for remdesivir. Versus if they're an organ transplant recipient, you may be more aggressive with your therapies. Regarding physical exams, always note the amount of oxygen the patient is requiring on admission. This may expedite certain treatment options. These are the pertinent labs. You do not need to memorize these, but these are in your admission order sets. I just want you to know that these are the labs that you'll order on admission, and usually some of these you'll trend daily. The one thing I do want you to note is please make sure you're ordering the COVID IgG on admission. This is important because it lets us know what phase of the disease the patient is in, also opens or closes certain treatment options. A chest x-ray. So if the ED did not order one, please order one. You want to make sure that the chest x-rays are consistent with COVID, and also evaluate for pulmonary edema. Correlated with the BNP, the patient may benefit from diuresis, and maybe you can keep them from getting intubated or increasing their O2 needs by diuresing if needed. The pertinent lab work I mentioned earlier, this is all in the admission order set, so just make sure you order it. We'll go over that later in the presentation. We'll talk about the phases of the disease and what our treatment options are. So if a patient presents within 7 to 10 days of onset of symptoms, then they're usually in the virulent phase of the disease. So that's where you can sort of hit them with everything. So if they're within 7 to 10 days of illness and they're requiring oxygen, then they'll likely benefit from remdesivir. Certain patients will benefit from remdesivir even if they don't have hypoxia. For example, if you have a patient with AIDS and a very low CD4 count, or a patient that's a fresh transplant and on immunosuppression, or a patient with lots of comorbidities and a high risk of decompensation, such as end-stage renal disease, congestive heart failure, or multivessel CAD, those patients will likely benefit from remdesivir even if they don't require oxygen, as long as they're presenting within 7 to 10 days of onset of symptoms. If you think your patient will benefit from remdesivir, reach out to ID and talk to them. And then if they feel that a patient would benefit, then you can consult them, they can probably order it. If the patient is presenting within 7 to 10 days of onset of symptoms and their IgG is negative, you as a hospitalist can order the convalescent plasma. It's under convalescent plasma. The one thing you note is you do need to have the patient sign a blood consent form. This is the regular TGH blood product consent form that you use for any other blood product transfusion. The one thing to note, as a doctor, you need to be the one to obtain the consent. You cannot defer that to the nursing staff, not for convalescent plasma. Finally, if a patient's hypoxic, as in they're less than 92% on room air, go ahead and start them on dexamethasone. The dose is standard, 6 milligrams daily for 10 days. If they have higher O2 requirements, you can change them to IV daily for 10 days. The dose is still the same. If the patient's presenting after 7 to 10 days, then really the only option we have is dexamethasone. That's again if the patient's hypoxic and the dose is still the same, 6 milligrams daily for 10 days. PO if low O2 requirements, IV if requiring high flow or heated high flow or intubated. Let's talk about where to place patients. So if a patient's requiring 2 to 6 liters, they can usually go to the regular COVID floor, which is the 4th floor of JEDI. If a patient, I would caution you that if they're already on 6 liters, they're probably better off on the 3rd floor of JEDI, which is ICU level care, because they can be closely monitored. Clearly, if a patient's on high flow, which is anything above 6 liters, heated high flow or mechanical ventilation, they need to be on the 3rd floor of JEDI, which is ICU level care. If your patient needs heated high flow, just please order the heated high flow order set. Just type it in as it's written on the slide. Hit enter. It allows a respiratory therapist to wean the oxygen. It saves you some time as well. This is one caveat you guys need to be aware of. Once patients are intubated and on the ventilator, they have a risk of going into acute renal failure. The way this usually presents is they may have a mild AKI. You may even think it's pre-renal from diuresis. The creatinine may just jump up by 1 point, but then it jumps up by another point or even doubles. Those patients usually end up in oliguric and anuric renal failure and require CRRT. So I would caution you that if you have a patient that's intubated on the vent with COVID, and you notice an AKI, have a low threshold, go ahead and get nephrology on board early, because that patient will likely need CRRT. Another thing to note is our COVID patients are a higher risk for DVTs and PEs compared to other patient populations at TGH. USF Maine, USF Pulm Care, and USF HEMONC have worked together to develop our own protocol that's based off the patient's BMI and their acuity of level of care. You don't have to memorize this, I'm about to go over it, but it's in the admission order set. So if the BMI is if they're going to the floor and the BMI is less than 40, just use Lovenox daily or heparin TID. If the BMI is greater than 40, and again, they're going to the floor, use Lovenox BID or heparin TID. Note the dosages that are different. Always continue SCDs unless contraindicated. If the patient's going to the ICU and there's not a confirmed DVT or PE yet, then you're going to use a higher dose despite the BMI. So if the BMI is less than or equal to 40, it's Lovenox BID or heparin TID. If the BMI is greater than 40, then it's 0.5 mg per kg BID. If the patient already has a confirmed DVT, PE, or their dimer is acutely increasing, then you're going to want to go and start treatment dose anticoagulation. And always use SCDs unless contraindicated. Again, you don't have to memorize these. These are all in the admission order sets. So one thing you're going to need to know is coordinating with PT, OT, and speech is vital to keeping these patients progressing throughout the hospitalization and keeping them from getting too deconditioned. So if your patient's a non-ICU patient, please consider PT, OT on all of them. It keeps them moving and keeps case management and social work aware of what their needs are on discharge, whether it's home health or a SNF or ALF. Even certain ICU patients, if they're not sedated or even if they're intubated on the vent but the critical care team wants to prone them, then PT can actually help with that and keep these patients moving. Any patient that's extubated needs a speech path evaluation prior to starting them on a diet. As of the time of this recording, we have a daily meeting at 11:30 via Microsoft Teams with PT, OT, speech, case management, social work, and TGH Transitional Care Clinic, where we actually discuss every single patient. PT, OT will notify the team of how they're progressing and what their needs are likely going to be on discharge. Case management and social work actually helps plan for any needs on discharge, and TGH Transitional Care Clinic is updated on when a patient's going to leave the hospital so they know when to contact the patient for follow-up. So let's talk about the admission order set and just walk you through it. So if you in orders, just type in COVID admit and hit enter. And the first option you'll see is the COVID-19 admission order set. That's your order set, so select that, hit enter. Notice your order set opens up. Notice the box I have outlined that under labs. You'll see two big arrows. One says labs, other. If you select that, that is where your procalcitonin and respiratory vital panel are. You can order those on admission. The other arrow that says known positive or strongly suspect positive for COVID-19, those are the COVID-19 labs that I described earlier that you'll want to order. So if you select the COVID labs arrow, you'll see your boxes will open up. The first box is the one-time labs. Those are labs you want to order for admission. The second box is the daily labs. Those are the ones you trend every day. So if you select the first box, many options are automatically selected. You can see them listed below. The one thing I'll note is the COVID IgG is not pre-selected, so please select it and order it on admission. Again, that allows us to know whether or not they're a candidate for plasma, also lets us know what phase of disease that they're in. If you hit the second box for daily labs, your options are pre-populated, so you can just move on. Towards the bottom of the order set is the DVT prophylaxis that I mentioned earlier. Again, you don't need to memorize it. These are radio buttons. It's pretty self-explanatory. Just click through, and based off the patient's BMI, which is already calculated in Epic, you can pick your options. Just click through the radio buttons. So once your patients are improving on oxygenation and they're under 6 liters, you need to start planning for discharge. Once you think your patient's ready for discharge, within 1 to 2 days, you need to order a home oxygen evaluation. And then coordinate with case management and social work to get home oxygen set up. If your patient's going home with oxygen, so not to a sniff, then they need to go home with some type of monitoring system. The reason for that is the TGH Transitional Care Clinic will be weaning these patients off O2 if appropriate, and the way they do that is through a monitoring system. So here we have two systems, and I'll go into details about those later. Use the COVID-19 discharge order set. It'll walk you through everything. Every patient you discharge needs a referral to the TGH Transitional Care Clinic. When you walk through the order set, they're pre-selected. You can choose between no monitoring, Massimo, or care companion. Any of those 3 options will automatically include the referral to the clinic. So let's talk about the Massimo monitoring system. So this is actually a device it's a probe that's on the patient's finger. It's connected to the patient's smartphone via Bluetooth, and it provides 24/7 real-time pulse oximetry measurements, and it's sent 24/7 to the care clinic, and it's monitored real-time by the staff there. If there's a disconnect, if there's significant desaturations, then they're going to call the patient's phone and check on the patient. It may be at 3 in the morning, it may be at 2 in the afternoon. And if the patient doesn't pick up after a certain amount of times, the clinic may call EMS to go check on the patient. So the patient needs to be aware of that and agree to all of that prior to you ordering that for them. Obviously, you want to make sure the smartphone is their personal phone and not something that's shared within the house. If a patient doesn't have a smartphone, or they don't have the capability for that, then there's another option called Care Companion. Essentially, you give the patient a pulse oximeter, and they can enter in their own measurements or their own vitals into MyChart, and the transitional care clinic can actually wean them off the O2 or manage them just based off their input into MyChart. So they need to have some type of smartphone or tablet or computer. Every patient that you discharge from TGH with COVID-19 needs some form of DVT prophylaxis. These patients are still at high risk for a VTE upon discharge, so you want to give them 1 month's supply of medications. Obviously, if they have a confirmed DVT, you send them home with treatment dose Lovenox for 3 to 6 months. But if they did not have confirmed DVT or PE in the hospital, then use the protocol listed here. And you don't need to memorize this. This is in the discharge order set, which I'll walk you through. The one thing I want you to note is this. Please make sure the patients have the medicines prior to discharge. Send the medications to TGH outpatient pharmacy and use meds to beds. You don't want the patient to go home without any of these meds and then they get a DVT or PE within a month after discharge. So if you type in COVID discharge and hit enter, the first option is listed as COVID-19 discharge panel. Go and select that, hit enter. And you got two main boxes. The first box is the monitoring system that I mentioned earlier. You pick which monitoring system or no monitoring system. Any of those three choices automatically includes the referral to the TGH Transitional Care Clinic. The second box determines which DVT prophy you want to send the patient home on. Again, this is if the patient did not have a DVT or PE in the hospital. Obviously, if they did have one, send them home a treatment dose Lovenox for 3 to 6 months. So let's talk about some final things. Please use the templates that we've provided. These are smart phrases. We have templates for the H&P, progress notes, and discharge summaries. The reason these are important is the ID team uses these templates to identify the pertinent information they need for their treatment planning. And the TGH Transitional Care Clinic refers to our discharge summaries for the pertinent information they need for follow-up for patients. Obviously, you use the admission order sets that we described. Another thing to note is there are going to be clinical trials at JEDI. At the time of this recording, we're not expecting the hospitals to be aware of every single clinical trial. They're not responsible for the management of these trials. These are run by the ID department. The one thing to note is these patients are screened on admission. If the ID department thinks that your patient's a candidate for a trial, they may contact you for permission to talk to the patient, or they may just talk to you about whether or not they're a candidate for that trial. Finally, I want to thank you. I want to thank you for helping us in this pandemic. We're expecting a pretty significant surge, and it's important that we have a common plan of care, and we have spent the past 8 months standardizing the treatment plan and the management of these patients. So I hope you're not feeling overwhelmed. I think after your first few patients that you treat here, you'll feel very comfortable. We have spent a lot of time with these order sets. We have spent time standardizing the treatment of care. And so I'm confident that each of you will be able to lead and continue the level of care that we've been providing during this time. So thank you again for stepping up and helping in this time of need. Have a good day.